The next section is a discussion on conduction abnormalities. Okay. One of the things that you have to look at when you get into dysrhythmia in the operating room is immediately you need to identify the cause. Don't just begin to treat the problem. Okay. That's how people get in trouble in the operating room. Okay. They don't begin to try to diagnose what the initiating event is. Okay. The first one that you always have to think of immediately is hypoxia. Okay. A tachycardia in the adult could be hypoxia. A bradycardia in a baby or a child could be hypoxia. Okay? So in a child, it tends to be more vagolytic, okay? And vagus activated, so you get bradycardia. In the adult, you get more of a sympathetic discharge, so you get the tachycardia effect. Okay? So if you start seeing PVCs, it could be also hypoxia. So arterial hypoxemia is the first thing you have to look at. So when you look at your screen, you look at your pulse oximetry, you look at your FiO2 that you're delivering in a patient. Okay? They had 3 deaths in Japan about 7 years ago, and one of the things that they, in the same operating room in the same morning, okay, and they noticed that all the patients got tachycardic right before they went into asystole, okay, and they couldn't figure out what was going on. Unfortunately, what they were doing is they were cutting corners, and they decided that they weren't going to have FiO2 monitors on the patients. Okay? The FiO2 is what actually measures the oxygen concentration that's leaving the anesthesia machine. And what's happening is that their operating rooms were being under new construction, and somebody had connected up the nitrous oxide to the oxygen line. So when they saw the saturation begin to fall, they immediately shut off their what they thought they were shutting off as nitrous oxide and bumping up the oxygen. What they were doing is they were converting the patient from a little bit of oxygen to 0 oxygen with 100% nitrous oxide. And all 3 people died. Okay? So always take that into consideration, even though because the pulse oximetry is going to show the desaturation, but if you don't know what you're delivering, if you don't know if your FiO2 is correct, you have really no idea. Okay? And does nitrous oxide have any smell to it? You have no idea. You have no clue. The other one that you need to think about is electrolyte disturbances. Electrolyte disturbances like just potassium and calcium and as well as magnesium are clearly important. We had a case the other day where we put somebody to sleep, and the student was kind of new, so I was watching him ventilate, and he's doing this. Okay? He's hyperventilating. Okay? And as soon as he starts hyperventilating like this for about a minute and a half, I'm just sort of watching him because I'm looking, okay, let's see what happens here. Okay? And all of a sudden we start seeing lots of PVCs, lots of really bad looking, ugly arrhythmias. So he looks at me like, oh, this is really bad. So he starts ventilating even faster. Okay? And I said to him, I said, son, why don't you just stop? Okay? So he stops ventilating. Says, okay, now just sit here and watch for a few minutes. And the arrhythmias, about a minute and a half later, went away. So what induced the arrhythmia? There you go. The hyperventilation took the potassium and drove it into the cell and made the person hypokalemic. Okay? So one of the treatments for hyperkalemia is hyperventilation. So if you have somebody who's normal kalemic and you start hyperventilating like crazy, you may actually drive them into the hypokalemic range and get a significant bradyarrhythmia, okay, or tachyarrhythmia. Okay? So most hypokalemic events tend to cause you tachydysrhythmia such as atrial fib or atrial flutter. On the other hand, if you get hyperkalemic, you go into asystole. Okay? So that's another one to worry about. If you go into B-tach, magnesium should be pretty much on your concept and your back of your mind. If you see B-tach that has alterations in the QRS, that's your hypomagnesium, which we call, what's it called? No, Torsades des points. Did you say that? I didn't quite catch it. Okay, torsades is what it's called. Torsades des points. Okay, which means in French to change your axis. Okay, which is the point is changing in its point of axis. That's why you're seeing the QRS actually altering the way it looks. Okay, so torsades are treated with magnesium and then it goes away. Acid-base disturbances, of course, is what I was talking about before. Hyperventilation or hypoventilation will lead to pH changes. which then can affect potassium levels. Okay? Altered autonomic nervous system activities, either from deep or pain from somatic. Somatic pain tends to cause sympathetic discharge. So in other words, if somebody cuts you in the skin, you don't get bradycardic. You tend to get tachycardic with that. But in deep pain, you tend to be more parasympathetically mediated. So if somebody pulls on your peritoneum, let's say the surgeon's tugging on the peritoneum, you can get into severe bradyarrhythmias. Okay? If you grab somebody's eye and pull on the eye real hard, you will cause what's called the oculomotor reflex to be taking place, and the heart rate will go to 0. Okay? Severe bradycardia. Okay? So those are the kind of things that can happen as well. You can also have increased myocardial stretch fibers, such as a reflex bradycardia from hypertension. You can get, when you intubate people in the trachea, that's a tremendous sympathetic discharge that increases heart rate, usually with a concomitant increase in blood pressure. A myocardial ischemia could be due to hypoxemia or lack of perfusion. Okay, drugs such as catecholamines, especially when combined with volatile anesthetics, specifically halothane. Halothane and epinephrine, if the surgeon is injecting with epinephrine with a local anesthetic, you can get some very nasty arrhythmias when you used halothane in the past. I'm not sure they're going to ask you that on your boards because halothane's not used that much anymore, but if it's an old-timer's making the test questions, you will. Okay? As the new volatile anesthetics, you tend to get tachydysrhythmias, especially when you use desfrane, SIBO. Once you get above desfrane of 1 Mac, which is 6%, you tend to go into sinus tachycardia. And you keep chasing your tail because you think the person's light, so you keep increasing your desfrane, and you see the heart rate begin to increase. It has nothing to do with sympathetic discharge. It's the autonomics being activated by the desfrane itself. Okay? Coexisting cardiac diseases can also be present, such as preexcitation and prolonged QT interval, and things like WPW syndrome can also cause very significant cardiac dysrhythmias. The action potential in this example is what you normally see in a pacemaker cell. Okay, the actual phase 4, which is drawn in the green line up in this board, just tells you the actual energy before it hits threshold. Once you hit threshold, then it goes and propagates the action potential. Okay, so that's where the threshold mark is. What actually do these sympathetics do is they increase the velocity of phase 4, so it reaches threshold more rapidly, so the heart rate is increased. As for parasympathetics, they actually decrease the slope of phase 4 to slow down the heart rate. So action potential, the ones that are responsible for phase 4 changes are calcium, but mostly due to slow sodium channel leakage. Okay, so you're looking at sympathetics and parasympathetics effect, mostly the sodium channel, and cause this effect. Okay, you can see in the other line, which is in the pink line, which is this one, that's a ventricular muscle cell, completely different. Okay, has to do with, it gets activated by the action potential that's generated through the pacemaker cells. So alteration to phase 4, things that increase the slope, which means they're going to reach threshold more rapidly. Arterial hypoxemia in an adult, hypercarbia, anything that induces stress, such as catecholamine release, sympathomimetic drugs, acute hypokalemia because of hyperventilation, hyperthermia, hypertension. So think of all a stress response. As for decreasing the slope, mostly that is due to vagal stimulation, and there's many different reasons for vagal stimulation, which I just told you about. Visceral pain could be one of them. Okay, eye reflexes could be another one. Positive airway pressure could also cause a bradycardia. Severe hypertension with reflex bradycardia could take place, and the other one that causes a significant effect on this is acute hyperkalemia. The arrhythmias that we're going to expect you to know for the test is you need to be able to differentiate. One of the things you want to look at first is look at the heart rate. See if the heart rate's fast or slow. It'll tell you if you have a tachydysrhythmia or a bradyarrhythmia. Okay, if you're under 60, you have brady. Over 100, it's a tachy. You want to make sure that the P wave is present. Make sure that your PR interval is adequate in length. Then look at the QRS. Make sure it's tight. It's under 100 milliseconds. If not, it could be you have a bundle in there or some kind of conduction delay problem in the ventricle. And then you look at your T waves to look for any kind of repolarization problem. The cardiac conduction initiates in the SA node, traveling down to the AV node, eventually going to the His Purkinje and the bundle of His, and eventually reaching the ventricular muscles, which generates a QRS signal. You also have what's called reentrant arrhythmias, which are sometimes called circus pathways. Circus pathways are basically the description of thinking when you go to the circus. You'll see that the animals, like the elephants, will go around in a circle. Okay, and that's what they're talking about, the circus pattern. The normal pattern is that the electrical activity only goes in one direction. If you have a reentrant arrhythmia, that direction can actually come back around a different portion of the heart and reinitiate the heart that should be stopping. Okay? So you can get this kind of circle rapid rhythm, and you can get heart rates up in the 200 range, which is not something conducive to survival. Okay? So you don't want to have these kind. The typical very bad reentrant arrhythmia would be Wolff-Parkinson-White syndrome, okay? Which I've been told that you would maybe see one in your lifetime, and I've diagnosed myself 2 in the operating room, and I've seen 5. So I would say that's not as rare as they used to say in the books. Okay? Arrhythmias is correct the source of treatment. Okay, then you consider the antidysrhythmic drugs first, next. Okay, but always treat the problem first from the sense of understanding the source. Antidysrhythmic drugs usually be considered secondary. Okay, if you're having ischemia, treat the ischemia, then the arrhythmias go away. If the person's in low on oxygen levels and you give them oxygen, then the problems go away. If the person's being hyperventilated, decrease your hyperventilation, problem goes away. If it's potassium, get potassium. Don't get the antidysrhythmic drugs first. What we'll do is next semester when we talk about pathophysiology and coexisting, we'll talk into the antidysrhythmics. And specifically, we'll talk about it, how they're associated with certain kinds of channels. And that way you don't have to memorize it, but rather understand it. If this arrhythmia gets really bad, you can either consider doing a cardioversion or defibrillation. Okay, cardioversion is usually when the heart is in a rhythm that you can reverse, okay, without shutting down the heart completely. It requires you that you actually sense the heart before you fire, versus if you use the defibrillation, you're firing so much energy into the heart that you're stopping the heart completely. Okay? It's a lot more dangerous to defibrillate somebody than to cardiovert them. Okay? It doesn't mean that cardioversion is not dangerous. It is. There's about a 5% mortality rate when you defibrillate somebody. Sorry, when you cardiovert somebody. So don't take it lightly. Okay? It's only usually used when somebody's becoming unstable. And there is appropriate times to do it. You can also use artificial cardiac pacemaking. We used to do that more often than not, but now almost everybody has a pacemaker. You know, if you look at Naples, we actually have 4 electrophysiologists, which means they're cardiologists that only work on the electrical component of the heart, and they work, 8 to 12 hours a day just putting pacemakers in every day. So we're looking at 13 to 14 pacemakers a day being put in per day. You got to ask yourself, wow, that's a lot. And the reason it's so much is because the antiarrhythmic drugs that were used in the past have been found to increase your mortality rate. Okay, so everybody said, give up on the antidysrhythmics and just go for the pacemaker. Okay, the antidysrhythmics really work great, like enconide and flecainide. They will stop your electrical arrhythmia completely. The problem is if your heart stops, guess what? You don't come back. Okay, so that's the bad thing about it. So it suppresses any kind of activity so effectively that you can't get the person back. So because of that, we've gone to pacemakers. Okay, now, what are we going to ask you for the exam? I have to be able to expand for cardiac impulse conduction. You got to know the difference between first, second unifascicular blocks and bifascicular blocks, also known as third degree AV blocks. The first degree block is seen very commonly in the operating room, especially when you do positive pressure ventilation on somebody. The PR interval will slightly increase in duration, but you won't see a loss in QRS signal. So it's completely benign. The person is not going to go into a bradyarrhythmia and die on you. They'll be fine. Okay, you just have to watch it. Okay, but it usually doesn't convert into anything bad. So you have to know what a first degree AV block is, which is what this is. Then we go into the second degree blocks. There's 2 kinds. There's high and low, which we call a Mobitz 1 and a Mobitz 2. Mobitz 2 is much more serious and much more lethal. Mobitz 1 is actually fairly benign. Okay? Mobitz 1 is also called the Wenckebach, and what you see in this individual, see that the PR interval begins to increase in its delay period and eventually lose the QRS. Okay? The danger of this disease process is that it's the upper chamber of the AV node that's diseased. So the actual putting in the bullets into the chamber that's diseased. So it's not a problem in the sense that the person is not going to go into complete third degree AV block. Okay, will this person be more likely to do this when they get positive pressure ventilation? Yeah, maybe, but it's usually not significant enough to cause you to be worried. So you can put somebody to sleep with this and not much of an issue. As for this one, it's a different story. This is second-degree AV block. Okay? What you see is no widening of the PR interval. Instead, you just get a loss of signal. Okay? It's showing you that it's an infranodal block. Okay? And it's much more serious because it can become a complete third-degree AV block, which go into a complete third-degree heart block. Okay? So this is much more serious. Be very careful with this disease because when you put this person under general anesthesia and you put that person on positive pressure ventilation, that's when they go into third-degree heart block. Okay? I had one cardiologist that told me one time, nah, this guy's fine. He's got a Mobitz 2. He'll be fine. Had a Mobitz 2 for 15 years. He's been fine. And I said, well, that's not what our books say. So I said, oh, he'll be fine. So I put the patient to sleep like you told me. Dumb. Okay? As soon as I put him to sleep, his heart rate went to 22. I was jumping up and down. Okay? Blood pressure was 60. Okay? So I had to put in a pacemaker in the guy myself. Okay? So I put electrical pacemaker wire in and got the heart rate back up. Woke the guy back up, and sure enough, it went back to 60 heart rate by itself because you took away the positive pressure. And the positive pressure is what gets you in trouble with this. So be careful. This person needs that last patient needs a pacemaker before he goes to the operating room. As for intraventricular blocks, you can get either a right and left bundle branch block. The right bundle is, you look for the rabbit ears. Okay? The rabbit ears are going to be in lead V1. Okay? R for, you flip them upside down. Okay? See the rabbit ears? Mr. Rabbit? Okay? That's V1. So in right bundle branch block, you see rabbit ears in V1. That's how I remember it. I'm kind of, act like a kid sometimes. Okay? Remember simple stuff like that. So just take the R, remember that it's a rabbit, flip them upside down, and it creates a V, which is V1. Okay, so a right bundle branch block will be seen with a rabbit ear pattern, which is you have a double R pattern, which look like rabbit ears, okay, in lead V1. Okay, or you will see a right axis deviation on your 12 lead EKG. Most of the time. Not always, but most of the time. Okay? If you look at next one, okay, why care, and also important clinically, is that if you have somebody with a right bundle branch block and you put in a PA catheter in them, it doesn't matter. You're not going to knock out the right any more than what is blocked out. Okay? So as long as you have the left working in that situation, it's perfectly okay. But if the patient has a left bundle branch block and you put Mr. Swan via catheter inside the right ventricle and you hit the right bundle, unluckily, guess what you have? Third-degree heart block. One of my students 3 years ago did this. Okay, we were putting up a Swan in somebody, and she was very nervous. It was the first Swan. So I was talking to her, said, just push the catheter in slowly. All she heard was push the catheter. She didn't hear the word slowly. Okay, so she jammed it, and sure enough, she hit the bundle, and guess what? We went right into a systole. So you got her back. How do you get him back? Pull back the Swan. It's the first thing you do. Okay? Then do chest compressions, and you get him back. Okay? So, yeah, it got a little scary, but the patient did fine. We did open heart surgery, and they got fine. So, but it was they were having open heart surgery, so don't worry about it. No, it can be scary. This job is very scary. I mean, you got to make light of it, but it's a crazy job some days. So you got to pay attention to all these little details that we give you. So a right bundle branch is actually a benign one of these two. You don't have to worry about a PA catheter knocking something out. On the other hand, the left bundle branch block does. Okay, you got to recognize it before you put in a PA catheter. The way you look for is you see the rabbit ears in the left. Just drop the L down and make it a lead 1. So lead 1 is where you see the rabbit ears. So rabbit ears for left bundle branch block is seen in lead 1. You tend to see an axis deviation towards the left as well. Not always, but most of the time. Third-degree block is not good because that means the AV node is diseased, and you're no longer using the actual AV node of fire. It's usually some kind of widening of the QRS. Usually you get a flipping of the QRS because almost invariably it's the ventricle pacemaker cells that take over. Usually their rate's around 30 to 35, so you're not looking at a very rapid heart rate. Okay? Causes of the third degree, the most important one is the old age. You get primary fibrous degeneration. You could also have ischemia taking place. You want to reverse that, or a cardiomyopathy. With cardiomyopathy, basically happens is the fibers get longer and it gets stretched and eventually they break. So dilations are not something good because they can start causing right and left bundle branch blocks. You can also get it from inflammatory diseases that actually attack the inner portion of the heart. Remember, where did I say the cardiac conduction fibers are at? They're right below the endocardium. So they're right next to inflammatory reactions that take place inside the blood. So inflammatory diseases such as ankylosing spondylitis, forms of myocarditis can all cause these kind of problems. You can also see it from open heart surgery when they replace a valve. Sometimes they'll put a needle through the AV node and knock it out. Okay, usually not the case, but sometimes, especially replacing the tricuspid valve, sometimes that'll happen. Okay, congenital-wise, some people can be born with it. You could be also from increased parasympathetic activity, drugs, as well as electrolyte derangements, such as hyperkalemia, which is something that we do all the time when we do open heart procedures. We actually cause hyperkalemic arrest to take place. The disturbance of cardiac rhythm is the next discussion, which is tachycardia. So we'll talk first, and then we go into the bradyarrhythmias and then to the more serious ones. Sinus tachycardia is actually the most common arrhythmia that we see in the operating room. Okay? So if anybody asks you what's the most common arrhythmia, the answer is sinus tachycardia. It usually indicates sympathetic discharge or pain-related syndromes. So most of the time if you add a little narcotic, the pain goes away, tachycardia goes away. Okay, it does not always mean that. It could be hypoxia as well, so you got to consider that always in your first party differential. Okay? It could be anxiety, pain, sepsis, hypovolemia as well. It could be from hypoglycemia, but usually under general anesthesia, that's not the case. So they ask you that in the board exam. They ask you, do you see sinus tachycardia in hypoglycemia under general anesthesia? And the answer is no. You will not see it. Okay, that's the danger of hypoglycemia under general anesthesia. You cannot pick it up by normally tachycardia. Okay? You will see anything that increases your basal metabolic rate will cause sinus tachycardia, such as thyroid storm or hyperthyroidism. You can also see sinus tachycardia in an MH. The next more common arrhythmia is a parasympathetic hyperactivation, which is sinus bradycardia. You'll see the normal P wave, normal QRS, and T wave. It's just a heart rate that gets below 60. If it gets too bad, it goes into this. This is the really most common cause of putting pacemakers in the United States is what's called sick sinus syndrome. Okay? And what's really bad about this is that you can see this patient has a nice period of asystole where what happens is within 2 heartbeats you're in the ground. Okay? You don't realize what's happened, you just go unconscious. Okay? So it only takes about 2 heartbeats to lose your consciousness. Okay? So not good, not something you want to have. Sometimes you'll see people come in with a fractured hip, and you got to really pay attention. You got to ask them, how do you fall down? You got to ask them the mechanism of injury. If they tell you, well, I tripped over the rug, or I tripped over Fido, or I stepped on the cat's tail and I slipped, that's okay. That's a mechanism. But if all of a sudden they tell you, well, I don't remember. All I remember next is I was on the ground. You should stop. Okay? We did that the other day. We had a patient who was being brought to us to do a hip fracture. I asked her specifically, what's your problem? How did you fall down? She says, I don't remember. I just remember being on the ground. Okay, got an EKG. She had this. Okay, guess what she went for first? Pacemaker first, and then we went to the operating room. We did it all the same day. Okay, but you can't do one ahead of the other one. Okay, you will find out why in a hurry. If you have atrial premature and junctional premature beats, you lose the P wave. This is a high junctional escape where you see the QRS interval is very tight. It's not very prolonged, so that tends to indicate you junctional premature beats. Then you have PSVT, which is supraventricular tachycardia. There's many reasons for PSVT. Most commonly is atrial fib or atrial flutter. Okay, what you have to do is you have to figure out what it is. It could also be WPW. Okay, and if you give the wrong drug, like verapamil, you end up killing somebody. Okay. So the thing you got to do is you got to diagnose it first. You got to figure out what is it, atrial fib, atrial flutter, do you have some kind of other kind of reentrant problem. So you give adenosine. Okay, usually it's given 6 milligrams of IV adenosine in an arm, and then you raise the person's arm fast So the medication goes into your bloodstream. Okay, the faster it gets into the heart, more likely it's going to work. What adenosine basically is a byproduct of metabolism of the heart. Okay? It tells the heart that it's overworking. So when you give it a high enough dose of adenosine, it's endogenous, so you can't be allergic to it. Okay? That's a good thing. The nice thing about it is that it's also transient. But it's really scary when you first give it. If you've never given adenosine before, the first time you give it, your heart's going to stop because a person's heart stops while you're sitting there looking at them. Okay? So, and you also got to tell the patient ahead of time, hey, you're not going to feel good, you're not going to like me, you're going to get nauseous, you're going to get lightheaded, you're going to feel like you're going to die. Okay? You got to tell the patient that ahead of time, because if he doesn't, and he's going to feel all those things, he's going to go like, what the heck did you just give me? You know? You trying to kill me, doc? You know? I've had that happen to me, so I tell the patients ahead of time. Okay? Usually what will happen is the heart rate will slow down, and you'll slow down enough, if it doesn't go completely asystolic for a very short period of time, you'll see it slow down enough to figure out if it's atrial fib, atrial flutter, or you'll see the delta waves consistent with WPW. Okay? If it doesn't slow down enough, you can give a secondary dose. This time you give 12 milligrams IV on the secondary dose, and that will convert some people. The way adenosine is told to everybody that it converts everybody, that's a bunch of nonsense. The only way it converts people is if it slows down the heart rate below 60, which most of the time it doesn't do that. So it's just good for therapeutics so you understand what the heck's going on. Atrial flutter is one of the things that will slow down too. This will give you that sawtooth pattern. This is very commonly seen. This is specifically seen in patients that have dilated atriums. So you got to consider this person possibly has MS, mitral stenosis, or somebody who has a significant mitral regurgitation. Those kind of considerations should be in your head some reason that why is this person developing atrial flutter all of a sudden. It could be just from old age too, or it could be that somebody punched them in the chest and they just got atrial flutter. And it'll go away most of the time, thank goodness. If it doesn't, then you have to consider anticoagulating the individual. And if you want to cardiovert these person, which is okay to do, you got to make sure that you don't have a blood clot sitting inside the heart. So what we do first, before we do this cardioversion, is we'll do TEE on all these patients and look at their heart, look at their atrium to make sure there's no blood clot sitting there. Because when you cardiovert them, then that clot will dislodge and then you'll get it systemically and the person will stroke out on you. Bad move. Okay, so you don't want to do that. The most common place where the clot will be found will be in the left atrial appendage. Left atrial appendage. Atrial fibrillation is the next one. Okay, this one can also be very, very fast. It can be heart rates as fast as 350 beats per minute. Thank goodness, I've not seen too many of those. Usually they're running 140, 130 is usually the normal. Okay, so you don't usually get that fast. You'll see this kind of erratic pattern. This person has no atrial kick at all, so you'll see no A wave at all. Okay, this one also will be inconsistent, and it will become, when you listen to the heart sounds, is the only one where you can say that the person is irregular in their heart pattern when you listen to the heart. So you hear blah, 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 blah. It's all over the place. You'll never hear an S1, okay, because it's not consistently firing at the right place. So you get a regular, variable S1, normal S2 is usually heard, and that's with the diagnosis of atrial fibrillation on physical exam. Junctional rhythms can be, of course, present. There's two kinds that are dangerous. There's ones that are really slow and the ones that are tachy. The ones that are slow are the ones that are deeper into the AV node, and they're more likely to get AV problems when they take them in the operating room. And you have wandering atrial pacemakers. The way you diagnose this is you see the P wave will be erratically present, and all of a sudden will show up inside the QRS, and sometimes it also will be retrograde. These people need to consider putting a pacemaker in them as well. Then you have PVCs. How do you diagnose a PVC? Well, PVCs are premature in their occurrence. That's why they're called PVCs, premature ventricular contractions. The second thing is they're absent in their P waves, and they have a widened QRS with an ST segment that's opposite in direction to the QRS. You have to fulfill that criteria. The ST segments must be opposite the direction of the QRS. Okay? You have inverted T waves as a consequence. You have a compensatory pause. And some of these PVCs are non-conducting. What they mean by non-conducting is that they don't have any pulse with it. So you take a pulse, your pulse oximeter will say heart rate's 30, and your EKG will say 60. That means you're in a 2-to-1 block, okay, and you're having a situation where the PVCs are non-conducting. Conductions, what are conditions associated with PVCs, you can actually have somebody who's normal. I had a patient who came in the other day, well, about a year ago now, that had bigeminy. Okay? Bigeminy means that every other beat was PVC. Okay? And what was interesting about it was non-conducting, and his heart rate was 35 according to pulse oximeter. And he was like 33 years old. So I was like, well, don't you feel anything different? Nope. Do you ever been short of breath? Nope. I said, well, you know what? You're not getting your hernia fixed today. You're going to see the cardiologist. So he goes, why? I'm fine. No. Because you know what? I might be wrong. I might be totally a normal person with bigeminy, but I want to make sure the cardiologist looks at him, puts a Holter on him, and figures out if he's got any problems. So I did everything on the guy. He was fine. He ends up, that's where he lives at. The Holter showed that 90% of his day was in bigeminy. The only time that he was out of bigeminy was in deep REM sleep. Then he was back in sinus rhythm. So the rest of his awake life, he was actually in bigeminy. So kind of interesting. So we put him to sleep, and guess what? He went into normal sinus rhythm. It was like really strange, but it followed what the Holter said. Arterial hypoxemia could also be the cause, myocardial ischemia, and all these serious conditions could also be related to hypomagnesemia. Caffeine will induce this, as well as cocaine toxicity, alcohol. I was having a lot of PVCs when I was up in Northwestern because they had Starbucks up there. First time in my life I've ever been exposed to Starbucks. So I was drinking 6 cups of Starbucks a day. The extra high caffeine doses, I was jumping up and down. So, but my heart wasn't really appreciative, and I started having lots of PVCs. So definitely the caffeine will do that to you, so be careful. Alcohol, mechanical irritation will also cause PVCs. This is VTAC. There's 2 kinds of VTAC. There's unstable and stable VTAC. Stable means that the person has a stable blood pressure. Unstable means that you're losing your blood pressure or no blood pressure is evident. Treat them very differently. One can be treated chemically, which is the stable. The unstable VTAC needs to go on to electrical, and decision tree can be cardioversion or defibrillation, depending on the seriousness that you're in. VFib, on the other hand, is always defibrillate. This person has no pulse. If you have a pulse, you don't have VFib. Period. Okay? Now, trust me, listen to me very carefully. There's some really nasty surgeons out there, and there's also nasty anesthesiologists like me, okay, who will try to see if you're awake. Okay? And you'll have a nasty surgeon who will be saying, student's up there, he doesn't know what the hell he's doing. So he'll go up to the EKG lead and go like this. And you will freak. Okay? Because you'll see this, and you'll say code, you know? All right? Now, if you see this, the first thing, think in the back of your mind, is Dr. Nolan messing with me? So look around, okay? Or if you see a surgeon, it's somebody else messing with me. But besides looking at that, you look at your screen real quick and see if you've got a pulse oximetry. If the pulse oximetry is still showing you the nice wave pattern, it's not VFib, okay? You also look at your end-tidal CO2 if you have the patient intubated, and if you see CO2 still coming out, it's not VFib because you lose all perfusion to the lung. So the CO2 goes to 0 in VFib. Okay? But on the other hand, if you see there's no pulse oximetry and 0 end-tidal CO2, yeah, then hit the code button because you need somebody to give you a hand in there. Okay? So this is one you need to get a paddle on the chest immediately. Now, I've seen somebody go into this and was just losing consciousness and hit him in the chest. Okay? Hard as I could. Okay? They woke right up. Okay? And they were out of VFib. Okay? Because you can generate 300 joules with your fist. Okay? Now, please don't just hit him in the chest. Okay? Okay? Make sure that the person's unconscious. One of my friends broke his jaw. We were walking through the ICU. He was an intern. You know, he was a third-year medical student like me, so we was like really green. And he sees this person who's reading newspaper, and all of a sudden he goes into VFib. The guy's just reading his newspaper. My friend goes right up to him, hits him in the chest. One problem, he was awake. Okay? And he was about 240 pounds, and he didn't have an ounce of fat on him. So when he swung and hit my friend in the jaw, his jaw cracked. So I'm going, dude, that was a really great, thump, but man, he was awake. What were you thinking? And so he's like, get me fixed, John. You know, so we had to send him to the operating room and get him wired for 3 weeks. So it was the only time he ever didn't talk for 6 weeks. So he was kind of quiet. So make sure that the person's unconscious. You can't stay conscious with this one, okay? You're unconscious for one thing, and you lose all your pulse. So that's how you diagnose this one quickly. But at the same time, don't hesitate. don't hesitate on this one. You've got to jump on it fast. Then you got pre-excitation syndromes. You have WPW, you have Long-Levine syndrome, Mahane pathway, and prolonged QT interval. We'll talk about those. WPW is something that occurs to you in the operating room and in somebody who's undiagnosed and usually does not have an EKG. Because you don't get EKGs on 20-year-olds. Okay? So what happened to my story, where I've had two of them happen, the first one we picked up as soon as we walked in the operating room after we put him to sleep. The other one we picked up in pre-op, so we got ahead of it. But the first one, we put the patient to sleep, 22-year-old guy was in fireman school. Okay? As soon as we induced him, put him to sleep, heart rate went up 140. Just, went away on us. Okay? So the person that was with us, I'm going to give him a little Rapamil. I said, no, stop, because, you don't know what you're dealing with. So I gave it a little adenosine, broke it. Sure enough, we started getting these delta waves. This is what's called a delta wave. See the PR interval? There is no PR interval. Okay? There's an accessory pathway that's letting electrical activity go around the AV node. So there is no PR interval. You get a delta wave. That's a bad one to have, because if you give Rapamil, what will happen is you'll knock out the AV node, but you won't knock out the accessory pathway. And what happens is the heart rate increases to 300 to 400 beats per minute, and you go into VFib. And it's hard to get out of. So you don't want to do that. The other thing that's bad about Rapamil, it's a venodilator as well as a vasodilator. So it'll make you hypotensive right when you need to keep the diastolic pressure up, and the person will crash on you. So don't give Rapamil unless you know what you're dealing with. Atrial fib is different. Atrial flutter, that is an AV conduction delay problem. That's okay to do that, but just got to be careful. Yes? You have a question or no? Okay. WPW, never treat with Rapamil. When you see it on induction. Sometimes pentothal has been okay to use, so does propofol. One thing you want to avoid is anything that sympathetically stimulates you, which will activate this. So ketamine is not a good choice. Okay? Maintenance, nitrous and volatile anesthetics are considered safe. The one that also gets you into trouble is Pavulon, which is pancuronium bromide, which is a non-steroidal muscle relaxant from the aminosteroidal class. The downside to it is it causes sympathetic stimulation, which increases the heart rate and can then throw it into a reentrant arrhythmia. Emergence, really it's unknown if you should give the anticholinergic and anticholinesterase drugs. All I can tell you is what's more dangerous, somebody who's muscle relaxed or somebody who's reversed with rapid tachycardia. My answer is it's much more dangerous for somebody who's not reversed, so I reverse them. Okay, the books say it's unknown, so my answer to that is don't muscle relax unless you have to. Okay, but if you have to, then you're sort of stuck with reversing them or keeping them intubated and taking them to the recovery room, keep them sedated for several hours to make sure the muscle relaxation is completely gone, and then you can extubate them at that point. Okay. And you have prolonged QT interval. The danger of this one is that you get the Q on T phenomena, which means you go into BTAC. This person can be induced from things like all the antiemetic agents, believe it or not. Metoclopramide will do this. The one that was specifically being touted as being a big problem was Zofran. Okay? But the Zofran that we give, it's 4 milligrams. It's a joke. What I'm talking about is the Zofran that's given for the antiemetics for chemo, where they're giving 100 milligrams of Zofran. That's when you get into the prolonged QT interval. But 4 milligrams, never. 12 milligrams is what we give maximum. Never see it. Okay? So I wouldn't worry about it. The drug reps are trying to frighten us to stay away from it, and they're just wrong. Okay? So watch what they're trying to sell you sometimes. Okay? They said they wanted to give us Anzimet. Hate that drug. It's one of the worst drugs I've ever seen. The person pukes through it, so Zofran is much better. Even though it doesn't cause any QT interval according to it, but if you give enough of it, guess what? It does the same thing. But nobody goes to high doses of Anzimet. That's where we'll stop for today. I made it in time. Okay, yes, any question? You don't have this one slide? The valvular function, I decided to give it next semester. So I give it to you next semester. So the only thing that you're going to cover is this this section here. I'm not going to cover the valvular section in this section. Okay? I cover it in advance in the next course, which is the pathophysiology. Okay? Not till next semester. That won't be on your exam. Okay? Valvular abnormalities, which is next semester, this stuff, I will give that to you next semester. I don't go into it now because what ends up happening is it's too much. It's a pathophysiology. It's not normal physiology. So I just left it off this course and moved it on to the other course. I talked about it in the other course anyways, but now I'm going to talk about it in more detail in the other course. Okay? You don't have to hear things like 10 times to get it. Okay?